Good afternoon, ladies and gentlemen. It's a pleasure being here. I have to tell you I'm really thrilled about what I have heard and seen this morning. Russia and the Russian Federation in general is doing a lot of great things in order to improve healthcare, and I am more than optimistic that this will be a field again where Russia will make a difference in the world. However, you're not there. The problem of quality and cost in healthcare is not solved yet. And, you know, I actually want to discuss two topics with you today. Very simple. The first one is, you are not alone. There is not the one place on earth that you simply have to look at and copy what they do, and then you are done. We all are facing very similar problems until today. And secondly, there is no magic silver bullet that is going to change everything overnight. We need to take a very, very comprehensive, holistic approach in order to fix the problems in healthcare. And the idea of this session is actually to highlight how this holistic approach might look like, the approach that we call value-based healthcare. My personal background is in medicine. I'm a physician by training, and I've been CEO of a German health system of 4,500 beds for 10 years. So when I talk to you today, I talk very much also with my personal experience in care delivery and also the struggle with the money that everybody is aware of. These are data that some of you might have already seen in this or a similar way. And they basically show you in a very, very easy way where the problem in financing healthcare today is. You see in the red line the growth of the GDP. So somehow, you know, the growth of the financial strength of a country. And then you see as a blue line what we are spending for healthcare. And the interesting thing is, wherever you look at, you see the same picture. If you look to the United States, you know, a country that is actually believing deeply in competition and in private health, it's probably the most competitive healthcare system you can find on earth. You see that they are struggling with, you know, the costs that are outgrowing the GDP. You see in NHS England, which is a public system, fully financed by tax money, National Health Service is basically setting the rules for everyone, sees the same problem. You see Germany, which is kind of a blend between private and public aspects. You see Sweden, which is more on the GDP side. Wherever you look at, you see the same problem. Costs are growing faster than GDP. And Russia is also part of that game. You see that there's exactly the same pattern in Russia than in all the other countries. So what does it tell us? It tells us this is an unsolved problem. And secondly, it tells us that the solution is not necessarily a political solution in terms of public versus private. You know, we have the tendency to discuss very often these kind of questions as political questions, like, you know, what is your belief? Are you believing in private? Are you believing in public? And the reality is, if you organize healthcare in the wrong way, it doesn't matter whether you are public or private, you will finally mess it up. But more interesting, we believe, than the issue of costs is the issue of quality. These are data that are collected every year at the OECD level. And it's probably hard to read, but I will translate it to you. It's pretty easy. These are data on a national level where they looked at deep vein thrombosis as a complication after hip replacement and pulmonary embolism as another frequent problem after hip replacement. And what you see is there is an incredible variation between countries. 16-fold variation between Poland and New Zealand. 63-fold variation. So the question is, why is that happen? I mean, do the guys in New Zealand don't have access to textbooks? Are the doctors in Australia not going to medical school? Are the physicians in Canada not using drugs? No, that's not a problem. All these guys who are practicing medicine around the world, they know the guidelines, they have the textbooks, they have basically access to care, and we still see dramatic differences in outcomes. These are data within countries. So now we are comparing the 25% best hospitals against the 25% worst hospitals in a country. And what you see is, again, huge variation, a twofold variation in the likelihood that you die with a myocardial infarction in the United States. Fivefold variation to have a reoperation due to a complication after knee replacement. I mean, we do 100,000 of knee replacements every year in Germany, and still there are hospitals who simply don't know how to do that. A ninefold variation in complication rates from prostatectomies in the Netherlands. Even in the Netherlands, where they have actually reduced the numbers of hospitals who are allowed to do these treatments, we see those data. And you know, a 63-fold variation in capsule complications after cataract surgery, the most frequent surgery that we know in general, and still such a difference. The interesting thing is, these data are exciting. I promise you, when you live in the Netherlands and you are suffering from prostate cancer, you really want to know what these hospitals are. When you need a joint replacement in Germany, you want to know what these hospitals are, and you typically don't get access to these data. We don't share these data, although they are there. And this is a big problem all over the place. These are differences in treatment intensity. I think it's a very, very important picture, because when you talk about healthcare improvement in middle-income countries like the Russia Federation, you very often talk about access. Give us access to more care, give us access to latest technologies, and then everything will be fine. You know, this is a reality. The likelihood that you get a CABG, so a coronary artery bypass graft for cardiovascular disease, in Belgium is 3 times higher than in Spain. And the question is that good for Spain? Or is it bad for Spain? Or is it good for Belgium? The reality is we don't know that. We simply know that there is a huge difference even within the very wealthy countries in terms of access to treatment. Heart catheters, 3-fold difference. Again, why do you get, you know, with a 3-fold higher likelihood a heart catheter in Germany than, for example, in Italy? And I tell you, if you look what is the difference between getting a heart catheter in the north of Italy compared to the south of Italy, it's probably a 10-fold difference. This is completely random. It's completely random. It has nothing to do with providing quality. And the same is true for many other medical conditions that we looked at. Prices. Another issue. You know, we were talking about, you know, prices, HTA, what is the right amount of money that we pay for a different, you know, medical procedure or technology. Again, incredible differences in prices. I don't know. I actually really don't know why the price for a joint replacement in France is half the price than in Belgium. These countries are next to each other, speaking the same language, at least in large parts of the country. People are going back and forth. Very similar histories, similar income levels, similar wealth, but such a big difference in price. And last but not least, the personal experience. And this is the way how we are actually practicing medicine. How do we, apply care practice? These are actually 2 hospitals that were part of my healthcare system in Germany. Both hospitals did very high volumes on knee replacements. And one day we were just sitting down and I asked my knee surgeons, is there anything that you can learn from each other? And they say, no, there's nothing we can learn because it is 100% clear how we have to do a knee replacement. And when we looked into the details, we saw that there were basically significant differences in the way how they did the knee replacements. There were huge differences in care practice wherever you were looking at. And they still believed this is standardized care. Ladies and gentlemen, this is a problem. This is a problem when we are talking about healthcare today. There are healthcare professionals, typically very well-educated people who are working very hard, people who have, very, very high ethical standards. And these healthcare professionals in different countries, or within the same country, or even within the same hospital or practice, are providing very different care in different ways, more and less frequently, at better or worse quality, at higher or lower costs and prices. And this is, unfortunately, the situation today in the wealthiest countries as much in the poorest countries on earth. So please don't do the mistake thinking we just have to look what's going to happen in the rich and wealthy countries around and let's copy paste what they are doing and then we end up with great care. That's not true. You are basically in a very favorable situation because you have the opportunity in some areas not to repeat the mistakes others have taken. I think that this is probably the most important picture that I want to share with you. It's an analysis that we have done in our work with the World Economic Forum. The World Economic Forum in Davos is a meeting that happens every year and it brings actually the political and the economic and the social leaders of the world together discussing about the most urgent problems of the planet. And one of the work streams in the World Economic Forum since 2014 is value-based healthcare. This is where this picture stems from, and what you basically see is, on this y-axis is the outcome, and in this case a very simple outcome. These are the, life expectancy years. And here you see what we spend for healthcare. And you can imagine the ones who are spending most per capita on healthcare are the United States. Here is Switzerland, somewhere here is Germany, and so forth. And then you look very simply, what is the life expectancy? And what you basically see is, no matter what you spend, spending more money does not necessarily lead to better outcomes. Secondly, if you start to copy the model of the Western industrialized countries in healthcare, you somewhere end up here. And I can tell you one thing, no matter whether you finally end up here or here or here, you will not be able to afford that. It will be impossible for Russia to provide access to healthcare to all citizens if you move this path. And this is a challenge. You have to avoid this path and you have to move up. And you see here, Russia has already left the ideal path in the way they are spending money for healthcare. and organizing healthcare. This problem, we believe, and this is also the, let's say, core message of value-based healthcare, has a lot to do with the way how we are organizing care, how we are incentivizing care, and what we, make as a major success criteria for healthcare. It was Michael Porter who wrote in 2006 this major book, Redefining Healthcare. And what Michael Porter basically said was, we have organized healthcare very much around costs. Healthcare somehow is a game where you are shifting costs around. You try to find someone else to pay your own bill. And we do that again and again and again. At the end, we end up with spiraling costs. But this is wrong. We have to focus on value. And what is value? Michael Porter keeps it very simple. He says, the ultimate goal in healthcare is to achieve good outcomes from a patient perspective. Good outcomes are the results that matter to a patient. The quality of life, the functional ability, the cognitive ability, the participation in the normal social life, to be pain-free, to sleep well, to have a good partnership. These are actually the outcomes that really matter to patients. And we have to measure to what extent we are improving outcomes, and at the same time, how much money do we need in order to achieve those outcomes. So a healthcare system that is striving for better outcomes at lower cost is superior to a system that is just increasing the number of interventions or is just trying to control for costs. This thinking was actually put together in a picture by the World Economic Forum. And it simply says, well, we have to start with with population segments. So people in a population who have a medical problem. For example, the people in Russia who have cardiac disease. And then we have to ask ourselves, what are the specific interventions that we can offer patients with cardiac disease? Surgery, catheters, drugs, lifestyle changes, prevention, and so on. We have to measure to what extent we are improving the outcomes and what are the costs that we are spending in order to improve these outcomes. And we have to organize care delivery around this medical problem. We have to set up informatics system to collect the data on outcomes and costs. We have to benchmark and to compare to others. And finally, we have to tie payment and reimbursement to outcomes. This is basically the overall thinking. The three key levers of value-based healthcare are, first of all, the measurement of outcomes. And we will hear today a lot about outcome measurement, because what we clearly see is once you are starting to measure outcomes, and once you are starting to share outcome data with physicians and later with the population, you will see that magic is happening. Doctors who see that they are doing worse than others are going to improve. Care teams who know that they are doing better than others will attract more patients. And patients who see where the best doctors are go to these best doctors. Secondly, we need to integrate care. In Russia, as much as in most other countries, there is a deep separation between outpatient care and inpatient care, general practice and hospital care. We have to integrate care around medical problems in so-called integrated practice units. And we have to develop the right financial incentives. It is simply a flawed system that financial success in healthcare today and value for patient are not connected. You can make a lot of money by pretty useless stuff, and you can easily get bankrupt, although you are helping every day your patients in a very meaningful way, wherever you look at. This is important to solve. If you look at this transformation roadmap for Russia, you can probably see 4 phases. The first one is start with pilots, start with individual organizations who begin measuring quality, who start to reduce the variation of patient outcomes, and who come up with better and more structured care practice around the patient. And Professor Frieden from Sahlgrenska is going to talk about her experience in doing that in her work as a leader of a large academic medical center in Sweden. Secondly, you need to standardize the way how you are measuring outcomes. Only if we find a universal language and a standardized way how we are measuring outcomes, we can start to compare and learn from each other. And Professor Ingvar from the Karolinska Institute is going to talk about standardization of outcome measurement and also, the data infrastructure that is finally needed. Public reporting is something that comes typically much later. And I know a lot of people are afraid about, if you put all the outcome measures in the internet, nobody will go to the hospital anymore. This is a step that happens typically much later. Sweden was collecting outcome data for many years before they started to make it public, and then actually it was a very important and powerful step. And we are going to talk about that. Also, Barbro Frieden will talk about the experience in Sweden from public outcome reporting and improvement that happens. And last but not least, we will see that health systems are continuously using data in order to improve. And again, you don't need to wait for the Big Bang that the whole Russian system is changing. That might happen for selected medical areas. Christina Sterna from Deerberg-Wittram is going to talk about her experience in measuring meaningful outcome and clinical data in a systematic way over a huge network of dialysis clinics, basically spread all over the world, in order to systematically improve and get better. So for all these 4 phases, we will have a few examples. Finally, we know that from value-based healthcare, everyone will benefiting. That's a good thing about value. Value is the only currency in healthcare that unites the interests of all stakeholders. In a value-based world, patients will be able to select the best providers based on outcome information. Imagine how good that is if you can pick the best hospital for your mother or your father when they are in need for help. You can use, the outcome information to manage your own expectations, also to take decisions, what is the right treatment for me. And this is done, for example, in Sweden, in the rheumatoid arthritis registry. You can use your own outcome data compared to others in order to manage your health yourself. Providers can use outcome data in order to compare to others, to learn, to improve, just and simply to become better, to avoid mistakes, to avoid complications, and by that way, to increase efficiency and to reduce costs. Suppliers, we spoke about the medtech and the pharma industry today, they need this kind of information in order to make a much larger contribution to healthcare than they have done in the past. Can you imagine that all big 5 companies in the United States that are producing implants for hips and knees today are offering you a full suite of solutions around outcome improvement, starting with patient segmentation, patient analytics, outcome measurement, patient education, rehabilitation programs, complication management, outcome comparison benchmarks. So the time is over that suppliers are only selling you pills or boxes. They are selling you more and more holistic solutions in order to drive value. These are the new allies that you will find in healthcare. Payers will send their patients, their customers, to the best hospitals, to the best doctors, simply to avoid unnecessary costs. Can you imagine that the largest private health insurance in Switzerland is sending their prostate cancer patients by plane more than 1,000 kilometers from Switzerland to the very north of Germany in order to provide them with care, because they simply know we save so much money on complications that paying the hotel and the plane, even for the relative, is not an issue for us. And last but not least, the regulators will start to become the ones who are really driving value-based healthcare by policy recommendation. And when you see what, for example, NHS England is doing today in order to drive value, to make outcome data available and comparable, and to move the payment models into this direction, you will see how good that is, and also how optimistic this all of us makes. We are happy that we have had the chance to be on board as BCG from early on by driving this concept. We believe, and I say that because very often people ask me, well, why is BCG driving that? It's very simple. We believe that value-based healthcare is going to change healthcare around the globe. We believe that healthcare in a few years from now will be completely different because of that, and we are heavily investing in that by the research that we are doing, by ICHOM that Martin is going to talk about, and by the work that we are doing with many systems and organizations around the world. And with this, I'm finished now. Thank you very much for your attention, and I'm looking forward to Martin and the others to follow. Thank you very much.